Hello, everybody. My name is Ahmed Shawky. I'm professor of cardiology at Ain Shams University, and welcome to the Academy. This is a very nice way to really interact and actually share knowledge and get more knowledge. Today, I'm going to talk about hypertension and how to manage. I always like to take it into consideration, like taking a case, for example. Let's take this male patient with repeated measurements of 150 over 90, and he is coming because of the recurrent headaches. He is type 2 diabetes for 11 years. First question, are there any precautions required while measuring blood pressure? Are we accurately measuring blood pressure? Actually, if you look at it from the guidelines point of view and the different ways of measuring blood pressure, it's very important. We have to take more than two readings. We have to measure, the both the upper arms and take the highest as the reference. Patient should be rested. Patient should have not been smoking, eating, or doing any physical exercise for the last 30 minutes. Very important to be done in a quiet room. Sometimes it is better for the patient to measure him or herself blood pressure with a validated automated blood pressure device, and then we have to repeat it every 3 to 5 minutes. So it's really important. The number one killer in the world kills 10 million people every single year. Sometimes we always go into the wrong measurements, and this might lead us to over and underestimation of hypertension. So the patient is hypertensive. What is the grade? If we have repeated measurements of 150 over 90, what are the grades of hypertension? Actually, hypertension's grades, according to the European Society of Cardiology, hasn't changed from years and years ago, with the optimal being below 120 over 80. Grade 1 hypertension starting at 140 to 159, grade 2 160 to 179, and grade 3 over 180. If you have either an elevated systolic or a diastolic, you go to the higher grade every single time. So a grade 1 diastolic blood pressure is 90 to 99, grade 2 100 to 109, and grade 3 110 and above. Why the increments in 10 for diastolic and 20 in systolic? Actually, it really relates to the amount of risk it confers. For every increase in diastolic by 1 millimeter, it is accompanied by the same risk if the systolic increases by 2. Sometimes we're not sure that the patient is hypertensive. Sometimes we think that the patient has white coat hypertension. So what to do? Are we needing out-of-office measurements? Well, actually in the guidelines you will see a lot of usage of home blood pressure and the ambulatory blood pressure. Of course, the ambulatory blood pressure can really improve diagnosis, especially when you're looking at daytime when the patient is asleep and the night surge. This is really important when the blood pressure goes up in the late night and early morning, or as we more commonly call it, the morning surge. So usage of these are very important. Why? Because we have a number of patients that have white coat hypertension, and number two, sometimes the masked hypertension in which the patient is low in the office and high at home is sometimes also seen. Not so common, but not uncommon either. What if we have hypertension diagnosed by home blood pressure or by ambulatory blood pressure? Are the cutoff numbers for diagnosing hypertension the same? Actually not. If you look at the office, it's over 140/90, but in the ambulatory, the 24 hours is over 130/80, and the home blood pressure lies in between with a cutoff point to 135/85. And if you take a deeper look, you'll find that there are so many indications now for the home blood pressure and ambulatory blood pressure, even not only for diagnosis, but also for follow-up of some treated individuals. And it is now a cornerstone to really diagnose true resistant hypertension, the use of these ways. So we grade the hypertension. We diagnose the hypertension. Do we need any investigations to assess our patients? Actually, basic laboratory investigations are very important, including the complete blood picture, especially the hemoglobin, the blood lipids, blood sugar, uric acid, potassium and sodium, and sometimes they say also calcium. Not to say, of course, the renal function because of the medications and the way we assess the risk of the patient according to her or CKD level, his or her. And of course, urine analysis is really important as a target organ damage, looking especially at the dipstick or the urinary albumin creatinine ratio, which is even better. Also, we need to assess for what we used to call target organ damage, where now we call it hypertension-mediated organ damage. And this depends on the organ, like the 12-lead ECG for assessment of LVH, of course, is not so accurate as other parameters. The urine albumin for kidney disease. We can also do an extended screening if we need more accurate assessment for the left ventricular hypertrophy, like echo. We can assess aortic and large artery stiffness. We can assess screening for aortic aneurysm or even coronary artery calcification if the patient really warrants a significant uh, for the test. So we did the investigations for our patient and we found microalbuminuria. There is LVH, as you can see with the ECG. Comes the big question. We know the number one cause of mortality in the world is cardiovascular disease, atherosclerotic in nature, the most common. So the next question is, what is the cardiovascular risk of our patient? We do not just want to control the blood pressure, we also want to reduce the cardiovascular. So if we look at how to assess for risk factors and risk categorization, there are two important things, not only the level of blood pressure, but also the stage of hypertension. Stage 1 disease is not talking about the blood pressure itself, it's talking about the amount of risk factors. Stage 2 is the presence of hypertension-mediated organ damage, diabetes, or CKD grade 3. Stage 3 is those with established cardiovascular disease or CKD stage 4. So actually our patient is a high-risk patient. Why? Not because the blood pressure is really high, but really because of the urinary albuminuria. This is really important. So hypertension-mediated organ damage just pushes the patient to a higher risk category. Looking at the patient being diabetic, of course, diabetes itself is now a very important risk factor since its advent. But here, if we're talking about the score system, the patient with any target organ damage related to diabetes becomes a very high risk. Those who have diabetes just for over 10 years, even without target organ damage, are considered high risk. And those very young patients with very shorter durations of diabetes are moderate risk. What is our targets? We said our targets are definitely cardiovascular risk prevention and also controlling the blood pressure. And controlling the blood pressure is actually numbers. This is really important. And the guidelines really changed in 2017 with the American guidelines coming up at putting everybody just below 130 over 80. The Europeans in 2018 put 140/80 and 130/80 is the next number. But they really took out two different categories, the elderly and those with CKD. Why the elderly? For fear of hypotension and postural hypertension, and two, the CKD for fear of complications from the extra drugs. And of course, we know from the SPRINT study that those who really had a very aggressive blood pressure lowering had a little bit more acute kidney injury. So actually it's 140, 120, don't go too low, preferably 130, of course, in all patients, and between 70 and 80 for the diastolic. So we agree. What would we do What would we use for treatment in such a patient or any hypertensive patient? Of course, we have to look at so many things, the risk category and the grade of hypertension. What if the patient doesn't have a high grade of hypertension and is asymptomatic but has established cardiovascular disease? You're going to write something because we here are not just treating the numbers, we're treating the cardiovascular risk. If the patient has grade 2 or grade 3 hypertension, regardless the risk, we're going to start with treatment. Not to say that all patients, regardless they're going to take treatment all of them once or not, they should have lifestyle interventions regarding low salt, exercise, healthier eating, NASH diet, and then we're talking about drug therapy. The blood pressure medications were so many, but of course after 2017, the main drug that reduce mortality are the RAS blockers, the thiazide and thiazide-like diuretics, and the calcium channel blockers. But look here in the 2023 European Society of Hypertension guidelines, the beta blockers have shown a little bit of recovery, but of course you see the lines are in black, not in blue, like the RAS blocker CCBs and thiazide-like diuretics. Why? Because the beta blockers very important to reduce myocardial infarction, heart failure, but actually do not reduce stroke significantly. And the guidelines since 2018 think of using a dual combination from the start in most patients. Of course, monotherapy can be given. Monotherapy can be given in those with very low grades of hypertension or very frail patients or those who are afraid for postural hypertension or those at very low risk. But of course, starting with dual combination has so many advantages, but definitely in one single pill, it will improve outcomes and improve compliance. The advantages of this combination therapy is not just a complementary mode of action, it also inhibits some regulatory responses, like say a CCB might do some ankle edema, and adding a RAS blocker will reduce this ankle edema. It's more effective, especially in severe hypertension, and reduces blood pressure variability. Of course, we can go to triple therapy, and if we do not really go there, we can think of more aggressive treatment and treatment of true resistant hypertension, the new terminology that is only diagnosed by ambulatory blood pressure as per guidelines now. So we're looking forward for the discussions. There's a lot to talk about hypertension. We just, put a teaser on what hypertension is. There's secondary hypertension. There is treatment of resistant or true resistant hypertension. Looking forward to the discussions and wishing this lovely academy and its really important coalescence between the three countries a very good forward case, a very good discussion, and improvement of medical science in every part. Thank you.